Just to say again, thanks very much for the introduction, Sue, and thank you to the Maternity and Midwifery Forum for the opportunity to share my research tonight. As I say, it's looking at safeguarding midwives' experiences of caring for pregnant women with substance dependency, and it's exploring really a relationship building and how they built relationships and how they managed to maintain those relationships. For ease in the presentation, I'm going to use midwives to designate safeguarding midwives and women when I'm talking about pregnant women with substance dependency, because it is a mouthful, and the number of times I say it probably would be here for about an hour. So why did I decide to look at this? And I think the thing is when you're going to dedicate a large part of your life to something, you really have to have a particular area of interest in it, because sometimes by the end of it, you will hate it with a passion. However, this is something that was a real area of professional and personal interest because of some of the things that happened in my younger years. When I started looking into it, there's lots of research there about women's views on maternity services and midwifery care, but there's less research exploring how midwives experience caring for these women. And the research that is there tends to look more at midwives in a hospital setting or in a clinic setting. And very few of them actually were midwives who were involved in caring for women in a continuity of care model. And when I looked at it, there was just no research to date exploring how these midwives maintain relationships with women in a midwifery-led continuity of care where they are the main professional for the women. So what was my study aim? My study aim was to explore how safeguarding midwives provided care, and in particular, like I say, around about the relationships. How did they build the relationships and how did they maintain those relationships? When you actually look at it, there's many differences in the job descriptions of safeguarding midwives. If you spoke to a lot of safeguarding midwives across the UK, their roles and their jobs would be completely different. Some of them are safeguarding midwives but have a solely advisory role, whereas other midwives, like the midwives in my study, actually provided care to the women, hands-on midwifery care. There was 5 safeguarding midwives who took part in the semi-structured interviews, and we did use what we call a visual inquiry technique, and that really was just picture cards. So it was cards of different pictures that the midwives could choose if they became unstuck when they were trying to describe something. All of the midwives were NMC registered, of course, and were qualified for 14 to 31 years. So there was a wide range of experience there. They cared for the women in a mixed caseload. So there was mixed vulnerability. It wasn't solely substance dependency. However, the focus that I wanted was with substance dependent women. And most of the maternity care was actually provided within the women's home. And that was an important aspect, and it's something that will be discussed later on in the presentation about the importance of place of care when it comes to building relationships. Not only did they do that, but they also accompanied women to their obstetric clinics, addiction clinics, and social work meetings and child protection meetings. So they really were that woman's advocate for her throughout her care. All of the midwives had demonstrated an interest in caring for women with vulnerabilities before joining the team. And it was about caring for women with vulnerabilities, not child protection. So there's a definite difference there, although they had an interest in that. And you'll see the next slide while I put that on is because 3 of the midwives had attained a postgraduate diploma in child protection. So that was an important facet of their education and their knowledge. So when you start off with this, you start off with questions. And see, it can start off, you've got one question, and then when you actually sit and think about it, it's about, well, what builds that question? And that's where you come in with your aims. So as you can see, the research questions were very much around about relationships. And it was all about, what was their lived experience? What was the nature of that experience? And what was the nature of the relationship? Did the midwives have any personal or professional qualities that were different, that actually helped them with an interaction? And then did they have any other experience or knowledge that helped them facilitate a supportive relationship? And one of the big questions for me, which has only got one aim, is that did this relationship with the women then change how they interacted with the wider multidisciplinary, multi-agency team? And you'll see that later on, my answer to that would be yes. And you'll see why I answer yes to that already later on. So the reason that I've brought this slide up is to kind of discuss my methodology, because I always think that that's important with research, is to actually understand a wee bit about what the underpinning is in it. So I used a relatively new study methodology, which is called interpretative phenomenological analysis. And that first came to light in 1996 by Jonathan Smith. However, it is now quite a recognised methodology in qualitative research. Its roots are in psychology, and its foundations are in phenomenology, hermeneutics, and ideography. And it's based on several philosophies and philosophers. So there's lots of different theories in this, and this is what I really liked about it, because I'm not a great believer in one size fits all. I think that sometimes blended approaches to things actually bring about a better knowledge base and a better understanding of what's happening. And it focuses on the particular of a participant's experience of phenomena. So in that way, it's what they call idiographic. So you're looking at a particular experience from a particular participant in a particular context. So it can get right down to, if you like, the nitty-gritty of what's actually happening. This is a really good slide that I like, and it's from Charlie et al. in a paper, and the references are at the end of the presentation as well, and it actually shows you how all the different philosophies and philosophers' theories come together to make this blended approach. But one of the things that I felt was really important was, as a midwife for 30 years, I could not take my knowledge out of that research. I couldn't do it. I'm not a great believer in Husserl's bracketing, because how can I bracket something? Because if I've experienced it, I was a midwife, I was a community midwife, I've cared for women with substance dependency. So how could I take that knowledge out of that? What IPA actually does is it takes cognizance of that researcher's experience, and you build it into your discussion during your research and your findings. So you take cognizance of that and you build it in, but you always come back to what your participants telling you. So it's quite robust in that way. I'll show you this in the next one, and I do make a wee bit of an apology for this, because it is quite about analysis. But I do think, again, analysis is important, and it's about understanding how robust this methodology actually is. Because qualitative research can be criticised for its lack of rigour. But when you actually sit and look at this, you can see through it just how rigorous this process is. So in IPA, when you start off, you're starting off with your interview. So you're doing a slight bit of analysis when you're doing your interview, because you're thinking about, it's an interaction, with your participant. The other thing as well is that then you're listening to your transcript, you're listening to your audio as you're transcribing. So again, you're getting a wee bit more understanding there of what's happening. And then the real analysis starts, and it's about reading and rereading. And when you're reading and rereading, for the first two readings, I actually listened to the transcript at the same time, so that I could actually understand the nuances and the inflections, that within the conversation, which would give a greater understanding to what the midwives were trying to tell me. And then it's initial noting. Now, I must admit, it says step 1, step 2, but I tended to do those those two things together, because I would make wee notes, about, what was important, what was coming out the page at me, and what did I find interesting and wanted to follow through. The next step is developing the emergent themes. So you're looking at it conceptually, linguistically, and descriptively. So you're actually looking at the three different prongs of how we communicate. But one of the other things that I did as well, though, is being honest, is I also made notes around about body language and non-verbal. So there were things in that too. So I was bringing all that together. And then what we did is I was searching for connections across these emergent themes. Now, for each of the transcripts, I maybe would have about 30 emergent themes. And then what I would do is I would stop with that. And then what you then do is you move on to the next case. You can't forget what you've learned with your first case, but you must set it aside, because you want to look at your next participant's experience, their idiographic experience, not your idea of what their idiographic experience is. And then you do all that, you come to emergent themes, and then you start bringing together all the information you have, and you're looking for patterns across the cases. What you then are left with is 5, which in the old parlance is called superordinate themes. Smith, Flowers and Larkin actually wrote a new book in 2022, and the new wording that they use is group experiential themes, which I feel is much better. I don't really like superordinate themes because it kind of makes it feel as if they're more important than some of the other themes that underpin it. However, I just feel that every one of them is just as important to the other. So the group experiential themes, I think, is a better way of describing it. So I came up with 5: transformation, tug of war, reciprocity, proxy parenthood, and midwives twitch. And each of those names come out of the feelings and the themes that were coming up. And as I go on through, when I'm talking about them, I'm going to be using the midwives' actual quotes to help you understand why I come up with this idea that it was transformation, it was tug of war, reciprocity, or whatever. Super and subordinate themes, transformation, tug of war, reciprocity, proxy parenthood, midwives twitch are all superordinate or group experiential themes. The sub-themes, or personal experiential themes in new terminology, underpin these. So you can see from them that there are different things underneath them. However, it gets a wee bit more complicated, because some of the superordinate themes are actually in more than one superordinate themes. So as you can see here, care and compassion actually found that was present in 4. Mutuality was present in 3. Midwife, reflection and reflexivity was present in 2. So you can see how it all interlinks and merges together to make this experience. So I'll start off with superordinate theme 1, which is transformation. Now, you can see here that there's the 2 sets of midwives quotes, and there was a distinct difference in how women, midwives perceived women from before they joined the team to after they joined the team. And that change was what I would call transformational. And Curator actually speaks about the difference between changing something and transforming something. And what she intimates is that change is normally for the outside in. It's in response to outside influences. It can be small and incremental, and normally there's not an awful lot of effort in the part of the person when they're undertaking it. So I would say that that's like you get a new guideline and you undertake and you use the new guideline, but you're not really thinking too much about it. You're changing your practice, but there's not an awful lot of effort in that, is there? But the thing with transformation is a lot of the time it's from the inside out, and it begins with a question or a purpose. So you're really sometimes questioning what you're doing, you're questioning the purpose of what you're doing. And it can be an internal fundamental change of your beliefs, and that can be quite challenging and normally requires quite a bit of effort to achieve that transformation. So you can see here that there was, quite a bit of a change. So how did that happen? Well, that happens through midwife reflection and reflexivity. And you can see here that Cameron, when they're talking about it, it can be slow, but in some cases it's an epiphany. And for Cameron, this was an epiphany because it was about, you know what? See, if I had been born into that family, that addict could be me. Because if I had to put up with what this young girl had to put up with, and then listening to her actually tell her story and tell her story how drugs helped her cope with that, made a huge difference to her. And it was something that came up quite a lot through the study. Was how about this transformation that the midwives went through. It was really, really important. And all the midwives actually, it gave an instance like this. This was just one of the most powerful ones, I felt. I know, can I just say, although some of the midwives' names are male, there were no men, there were no male midwives. It was all female. And the thing with that is that they picked their own pseudonyms, some of them. So at the end of the day, so that was why the names are maybe seem a bit unusual. But no, we didn't have a higher ratio of male midwives than others. So another part of transformation is time, the importance of time. And that's a huge thing for midwives. Midwives felt a lot of the time when they were maybe working in the community, they didn't have the time to be able to connect with women, because when they were in a clinic situation, they had 10, 15 minutes per woman, something happened, they did, so they were always aware that there was other people sitting in the waiting room. So a big thing about it was the working environment. We all understand that when you're working in clinics or you're working in hospitals, you've got competing demands in your time, and it can be really, really difficult to actually be able to just sit and talk to somebody and find out, what's really bothering you, what is going on with you. And the thing is that it's this thing as well about they really appreciated the ability to work autonomously, to manage their own diary, and to be able to give the women that they perceived needed more time. And that's what built the relationships. The next one is tug of war, a superordinate theme. And this came about, there was two aspects of it. One was with maternity services and the other one was social work. Now, maternity services, it was more along the lines of relationships or lack of them seemed to be integral to how the midwives worked alongside the midwives in the hospital, and how the midwives in the hospital sometimes perceived the women that they were given over to their care. And another big thing for them was that they didn't appear to know what the safeguarding team was about, and just how difficult their role could actually be. So I think that caused friction and a bit of tug of war around about, well, I do know these women, I know what's best, because I understand where they're coming from. And maybe if you understood a bit more, you would be able to care for them in a more appropriate way. I'll not say a better way, but in a more appropriate way. But the big area of friction was when there was competing multi-agency philosophies and priorities. And you could always say that, okay, in this case, this was between social work and the midwives caring for the women. But you could also put it to anybody, if you look at obstetrics and midwifery, we've got completely different philosophies. I'm a bit contentious, but we do have different philosophies around about our care, so that can cause friction. Although we work together well, most of the time it can cause difficulties. So for the midwives, they felt that the social workers' main focus was on child protection. And although the midwives' focus was on child protection and keeping that child well and safe, they felt that the way to do that was through protecting the mother and keeping the mother safe and well. So they would always advocate for the mother. And sometimes it was about trying to get social work to see that a well mum is a well baby. So how can we support that? The other thing as well is that they would advocate really strongly for women when they felt that women were being treated unfairly. And in particular, one of the midwives was saying around about, you know, how some of these young women, because of the cyclical nature of poverty and addiction, were already known to social work. So they were kind of written off before they even got to the point of you know, child protection assessments and things, and they would advocate very strongly for these women when the need came. So reciprocity, and this was one of the ones that actually underpins a lot of the relationship building. And for them, midwifery continuity was absolutely fundamental to relationship-based care, and how this reciprocity was built up. Seeing me, seeing you, probably quite a strange one, but some of the midwives had actually had some challenges, you know, growing up. And you can see here one of the midwives says that, you know, it's how I was brought up. I kind of know to a degree what these women are going through. But the other thing is that aspect of being able to see aspects of themselves, of their life circumstances in the women that they care for. And then there was the knowing me, knowing you. And this was a big thing as well, was because you're really getting to know them. And that comes back to midwifery continuity and having the time to sit and actually listen to the women and see what is their life story. You know, how can I help you? And how can I make this journey easier for you? One of the other things was normalise, not stigmatise. And this was actually, the interviews were in 2019. And this was when we were looking at the Best Start in Scotland, which was a lot around about midwifery continuity. And it was felt that Best Start would allow the kind of normalisation for the women who maybe were on substitute programmes such as methadone, where they were stable, they were well. So if they were in what they would see as normal antenatal clinics or being cared for in a midwifery-led continuity care model, but within a lower risk caseload, then maybe that would help normalise the situation that they were in and make the mums feel more normalised. The other thing was mutuality. And this was about, you know, not doing for, but doing with. And it's about empowering decision making. So it's not about taking the control from the women and saying you need to do this or you need to do that. It's about actually, well, look, see if I can point you in the right direction. You know, if you make these steps, maybe you can make that difference yourself. And midwives believed that by doing that, then those changes would be more long lasting. So listening. I like this quote because it says, you know, they might be just talking absolute nonsense, but it's really important because for some of these women, nobody listens to them. Nobody. You know, they go into their GP or they go into their and they just think, oh, here she comes again. But the thing is, let's say it might not be important to you, but it's important to them. And they felt being able to listen to the women made a huge difference. And walking the tightrope, this goes back to the transformation, what I said earlier about transformation not being easy, because we all have beliefs and attitudes, and a lot of them are ingrained. And you do try not to judge people, but you can't help being human yourself, and sometimes you will, and that's normal. But it's about how you then reflect on that and then move forward. A lot of these women, and in particular when the midwives were talking about this, they are involved in criminal activity. And, it can be difficult for the midwives, who have got a moral compass, that is different, to actually be able to do that. So sometimes they might not like what they do, but they like them and they will care for them, 100% genuinely care for them, as one of the midwives says later on. And then balancing relationships, and it's balancing relationships around about, making sure that you're not building reliance, because what you're trying to do is build empowerment and self-reliance. So it's walking that tightrope and, you know, like kind of that balancing thing about making sure you're not being too much of one and not enough of the other. This was huge, the power of the women's narrative. Listening to women's story is the most influential thing that these midwives told every time they would come back to it, you know, and understanding that it's life circumstances that bring people to addiction. It's not just they woke up one day and they decide, you know what, I'm just going to start using heroin. So proxy parenthood. Proxy parenthood come in through actually looking at the linguistic patterns within the text, and it was demonstrated through some of the words that they use, things like protection, care, compassion, nurturing, support, guidance, lots of the things that you would, you know, if you spoke of a parent, you would think that, well, that's what being a parent is. And this vicarious parenting was actually highlighted in a study of psychologists who were caring for children with adverse childhood events. And what they were actually doing is that they started to find themselves parenting the children, but they also then started to find themselves parenting the parents, so that the parents would then parent the children in a way that they felt was appropriate. So that was where this kind of came from. And they kind of spoke along the same way, using much the same language. It was more common when the midwives were speaking about young women who they felt had limited maternal or paternal support. So sometimes kids who were in care and things like that, they would feel quite maternal towards them and would demonstrate that. And then the next thing was courageous conversations. And this is sometimes about boundary setting as well. You know, as a parent, you set the boundaries of what you expect that relationship to be. And the midwives definitely did that with these women. They would set out the parameters about what their expectations were. But the big thing around about it is that even if the women moved away from that, they never gave up on them. They never gave up on them, and this will come up later on. Courageous actions. Again, midwives will go into places that other midwives, not other midwives, but other professionals won't go. And a lot of the time, because the care's in the home, they're doing first visits, they're doing booking visits, and they're doing them in the home. And like I said before, there can be criminality around about that. And if the guys who've been involved or their partners have been involved in criminal activity and criminal justice is involved, sometimes things can be challenging for the midwives when they're getting into these environments. But I asked them, I said, well, why do you do it? Well, why no? They can't come to me, so I've got to go to them. So sometimes they're aware. When you're a community midwife, you know, there was a block of flats I knew as a community midwife that I had to watch, and I always made sure I let somebody know when I was getting in and I let somebody know when I was coming out. Know that I felt, because there's always that respect in the community there for midwives, I think. It seems to be inherent. And know that I thought for 1 minute anything was going to happen to me, but always like just to be sure. So the other thing as well was this tenacity, and like I was saying earlier on about, you know, sometimes things happen and midwives kind of feel that the parameters or the boundaries get pushed and pushed and pushed. But having said that, is that if the women then feel that they've let the midwives down and they then start to kind of push the midwives away, these midwives will continue to search for them. Like one spent 3 hours looking for this young girl. The other one was saying, I mean, I think they're all Sam, these ones. And basically what she was saying is I don't care. All I care about is these women and making sure they get the care that they need. Because, you know, they are human, and if they've had a blip, then that's fine. We're all human. I have blips all the time. So that's thing. And it's this thing again about no walking away. And what she felt is that once the women realised that they weren't walking away from them, that trust was being built up, and that was absolutely huge. And the midwives really felt that was important. Care and compassion. you can see the thing is, you know, I genuinely 100% care about the outcome. You know, you don't switch off, just constantly think about them. And that's important. But then that brings into the next part about safeguarding midwives and their emotion work, and the fact that we're going to be looking towards trauma-informed maternity services. You know, to be able to support the women, we have to support the midwives, and we have to ensure that the midwives have the support that they need. And I think that the kind of support we should be looking at is like clinical supervision, such like the Family Nurse Partnership have, you know, in particular for specialist midwives who sometimes when you're listening, if you listen to what Cameron was saying, these are really traumatic stories they're listening to. So we have to make sure that the midwives are looked after and that they're kept as well as they can be. Now, this is our whistle stop around about knowledge formation and ways of knowing in midwifery, and this is about the midwives twitch. Now, this alone was just under 10,000 words in my thesis, so it's a huge part, but it's theory driven. And I'm just going to give a total whistle stop tour and an example at the end of it as to why I think that it's important. So when I was looking at it, I couldn't actually find anything along the lines in midwifery. There was some midwifery articles and literature around about how midwives learn and how midwives know, but this to me resonated. So see, for the bit about nursing, you just put in the word midwife and we'll be fine. But I couldn't put the word midwife in because obviously that's not what Carper spoke about. So Carper back in 1978 spoke about how the 4 patterns of knowing in nursing. But so we talk about empirics, which is basically your academic learning, which is your midwifery theory. And then you get your aesthetics. So that's really, as I would say, the art of midwifery. So it's where you're using that scientific knowledge when you're caring for your women. Personal knowledge, that's all the different things that we have. Now, personal knowledge covers a wide range of subjects, but it's about how you use that along with the other two and use the confidence to act accordingly. And you need confidence to be able to do that. And then ethics, which is the moral component. But as we all know, that can be difficult to define. But we all have a kind of moral compass that we use. These 4 fundamental patterns were then enhanced by unknowing by Munn Hall, which basically says that I'm quite happy to tell you I don't know what I don't know. And sometimes that can be hard for professionals to actually admit, I'm sorry, I don't know, but I'll find out. And the worst thing you can actually do is no and then just try and bluff it. And then the social-political knowing by White in 1995. And that's really important for midwives and how that underpins, because it's really about, you know, inequalities in health and how patient and women's well-being affects how their babies are and how they are. So what was the midwives twitch? What it is an intuitive use of all the knowledge that we have, and it's what I identified was a mechanism called phronesis. It's sometimes described as practical wisdom, but it's actually just an amalgam. The best way to describe it is it's just an amalgamation of all the knowledge that we have, everything that Carper, Munn Hall and White talk about, and then it's this using it in a moral way for the best interests of the people that we're caring for. And basically it's a gut feeling. Now, I do not know a midwife on this planet that hasn't a gut feeling about something. I don't know that, I just don't know what's going on here, but I know something's going on. So this actually has 2 aspects of it. It shows you how the midwife uses all the knowledge that they have to actually basically get a case overturned. It was going one way, and then she just happened to make a particular sentence because of how this man made her feel. But the other thing around about it is it's about continuity of care, because we know continuity of care builds and supports relationships with women, but it actually supports and builds relationships with the wider team, because they're in a particular area, a particular geographical area. All these people in this child protection meeting knew one another. So they knew when this particular midwife says, there's just something. But the other thing as well is because that midwife knew everybody round about there, she felt safe to say, This is a gut feeling I've got. So that's relatively new as far as midwifery continuity of care goes. We know that. So this is a thing around about, well, actually, it supports that relationship, so therefore supports safety. Next, so what? I always say, you know, we all do this and then it's so what? And really there's no surprise in any of that when you see what the presentation has been before. And then the other thing as well is that you do this and then you think you're going to answer things, and then what actually happens is that you end up with more questions than answers. And that's my research that I think should happen. Now, there's a couple of bits in here that I think stepping stones will be really, really helpful in answering. And that's the first one about women's experiences of being cared for in this, you know, midwifery-led continuity of care model. And the other thing is around about the place, you know, how does the place of care affect that? And then, like I say, my big thing is that I always feel that when we're looking at models of care, we always focus on medical outcomes, we always focus on clinical outcomes, and I feel we should be looking at psychological and social outcomes as well. So basically that's me. So thank you to the midwives who took part in my research, because they were very candid, they were very open, which is not easy. And thank you so much for listening.